بسم الله الرحمن الرحيم. تكملة محاضراتنا about the anatomy of the heart. اليوم هنتكلم على موضوع كتير مهم الحقيقة، وهو أساس الفانكشن of the heart, which is the contractility of the heart, which is being achieved through what is known as the conducting system of the heart. You know, looking at the contractility of the heart, which is being controlled by two systems, mainly this conducting system of the heart, and this is modulated by what is known as the autonomic nervous system, which is, as you know, it is being divided into the parasympathetic part of the autonomic nervous system and the sympathetic part of the autonomic nervous system. But keeping in mind that this autonomic nervous system will not be functioning properly except after the conducting system being functioning anyway, either a perfect way, even or even with some other diseases like whatever abnormalities or pathology could be. But basing of the contractility of the heart is is to be achieved really by this conducting system of the heart, which is very essential for the heart to do its inherent function. You know, a cardiac muscle tissue, as you know, has the intrinsic ability, inherent ability really, to number one is to generate those muscles or specific parts in the cardiac muscles are generating and conducting the impulse spontaneously, autonomously. You know, the signals of these cells are to contract rhythmically at the heart rate, which you know normally it is ranging between 70 to 80 beats per minute. The atria contract first to start with. An impulse pause, there will be a pause of this contractility of about 0.11 second at what is known as the EV node, which is main station really, one of the main stations of the conducting system of the heart, so as to give a chance for the ventricles to fill. Then the ventricles will contract so as to push or to pump the blood through the aorta and the pulmonary trunk, so as to complete the circulation of the blood. You know, the conducting system is a sort of series of specialized cardiac muscle cells, starting at the SA node and with its own inherent rate of contractility, as we mentioned before. You know, if we are to have to look at the general plan of the conducting system of the heart, mostly it could be simplified in more or less five stations. And those five stations are starting by what is known as number one, as in the diagram, really, in this diagram, at the sinoatrial node or the SA node. This SA node is known as the pacemaker of the contractility of the heart, the pacemaker of the conducting system of the heart. By itself, let us say, or autonomously, it gives the contractility, as we mentioned, from 70 to 80 impulses per minute, leading to atrial contractions, which will initiate the contractility of the heart. There is something called as internodal pathway. We shall explain this by the end of this lecture, but this is some sort of interatrial pathways, and it is being located anteriorly, posteriorly, and in the middle part of the heart, which is contracting, leading to the or helping the contractility of the heart intermingled with the atrial muscles. Then coming from the SA node is the AV node, atrioventricular node. And the conductivity at the AV node is very important in here. Important simply because reaching this AV node, atrioventricular node, there will be some sort of a pause of conductivity of the activities of this conducting system of the heart. This pause is about 0.11, as we mentioned before, seconds at the EV node, so as to give the ventricles the chance to be being filled, then to push the blood to the big structures, aorta and the pulmonary trunk. Then coming from this EV node is what is known as the atrioventricular bundle, or the bundle of Hess. And this is connecting the contractility or conductivity from through the system from the atria to the ventricle. This bundle of Hess is divided just at the uppermost of the atrio or the interventricular septum, so as it will give two septorially, two branches, the right and left bundle branches. The AV bundle branches conduct impulses through the interventricular septum to the ventricular muscles and being ended by the Purkinje fibers to give the contractility of the ventricles. Right bundle passes specifically here, and it is distinguishing the right ventricle, the right bundle from the interventricular septum. It will be passing to the anterior wall of the right ventricle through what is known as the moderator band. And this moderator band, as you remember, it is one part of the papillary muscles of the heart, or some projections of the papillary muscles inside the right ventricle, and such a band is not available there on the left ventricle, and this is another difference between the right ventricle and the left ventricle, pathway of conductivity being carried to the walls of the atrium. Then at the end, the terminal fibers, or the terminal branches or activating ones of the conducting system of the heart is known as the Purkinje fibers, and those stimulate the contractile cells of both ventricles, starting, and the very, very, very important real here, just to keep it in mind, to imagine how the contractility starts. It starts at the apex of the heart, then being moving superiorly from the apex to the ventricle and so on, so as to complete the actions of contractility of the heart. If we are to talk about in more detail about the stations where this conducting system of the heart starts and how does it work, and the locations of those stations in the conducting system of the heart. Starting at the sinoatrial node. Sinoatrial node, it is situated in the anterolateral part of the right atrium, located specifically here in the wall of the right atrium, in the upper part of the sulcus terminalis, just to the right, just to the right of the opening of the superior vena cava. Let us keep this locus in mind. It will help, in understanding some other pathologies later on. Coming to the next station is the atrioventricular node. In the atrioventricular node, let us talk about what is known as the triangle of Koch. And this is located on the lower part of the atrial septum, just above the attachment of the septal cusp of the tricuspid valve. We know the tricuspid valve is having anterior, posterior, or inferior, and septal cusp. The speed of impulse conduction through the EV node is 0.11. It is less than other pathways specifically in the atrium, and this time is needed really giving the chance for the ventricles to fill with the blood, so as to be filled, then after that pushing the blood to the aorta and the pulmonary trunk. From the AV node, we are going to the atrioventricular bundle or bundle of Hess. And this bundle of Hess is passing from the AV node through the membranous septum, interventricular septum, usually located on the inferior posterior wall of the membranous septum, where it descends behind the septal cusp of the tricuspid valve and then divides at the upper muscular septum in the right and left bundle branches, and those left and right bundle branches are there being going through the interventricular septum. The right, the next station is the right bundle branch and the left. On the right side, you are having the right, and on the left, you are having the left. The right bundle branch passes down on the right side of the ventricular septum to reach the moderator band, as we mentioned before, where it crosses to the anterior wall of the right ventricle, where it becomes continuous. It will be intermingled with the fibers of the Purkinje plexus as to conduct the impulses to the cardiac muscles. Uh, for the left bundle branch, it pierces the septum, interventricular septum, and passes down on its left side beneath, just beneath the endocardium, and this is usually divides into two branches. The left bundle branch usually divides into anterior and posterior branches, really. And this is important, really, if we're talking about some disease later on, like something like left bundle branch block, right bundle branch block, which part of the conducting system is being affected. And this will be shown on some investigations like what is called as echocardiogram. We shall give an idea by the end of the lecture about the ECG, which eventually here, after being divided, the left bundle branch into anterior and posterior, eventually become continuous with the fibers. Exactly, those, bundles or uh, they are finishing this courses, are ending this courses by being continuous with the fibers of the Purkinje plexus on the left side, like there on the right side. For the Purkinje, the last station or the terminal part of the conducting system are the Purkinje fibers or the Purkinje plexus of fibers, and those are situated subendocardially. And they are specialized cardiac muscle fibers that form the conducting system of the heart. This is the final stay for it, so as to give the contractility uniform. Let us mention about something some people are talking about as being controversial, but still, I think let us keep this in mind. What is known as internodal conduction paths, and those pathways are being activated just on the sinoatrial node, pacing the pacemaker of the heart being fired. Those pathways they'll be going through the atrial walls and reaching the AV node so as to continue the contractility. I think let us think of it more serious, and this could be a real event just to keep it in mind. Some people are talking about controversial, but we have to know that. It has been found that impulses from the sinoatrial node have been shown to travel to the atrioventricular node more rapidly than they can travel by passing along the ordinary myocardium. And this is significant in order to let the impulse being reached as much as possible, as early as possible, I mean, to the AV node. This phenomena, it's like a phenomena, is postulated due to a mixture, different types of tissues, different types of muscle fibers, modified anyway. It's a mixture of fibers and ordinary cardiac cells, and it has been passing through three pathways: one anterior, one posterior, one in the middle, just in between, according to the diagram, which you could interpret easily in this diagram. The anterior internodal or internodal pathways And it has been named against the one who described that, one of the famous surgeon, Bachmann's bundle, and this leaves the anterior end of the sinoatrial node and passes anterior to the superior vena cava opening. It descends on the antral atrial septum and ends in the atrioventricular node. Then the middle internodal pathway, Wickenbach's one, and this leaves the posterior end of the sinoatrial node and passes posterior to the superior vena cava opening. It descends on the atrial septum to the atrioventricular node, EV node. Then the last one is the posterior internodal pathway, uh, and named by Thorel, leaves the posterior part of the sinoatrial node and descends through the crista terminalis and the valve of the reminence valve of the inferior vena cava to the atrioventricular node. Those pathways, just keep it in mind as if it is making a complete series of events or pathways from the sinoatrial node reaching there to the Purkinje fibers, and it is a complete chain of actions, complete chains of pathways to let the contractility from the atrial node being reaching to the Purkinje plexus of fiber. As we started earlier in our talk today about the contractility of the heart is being conducted through two main systems. The conducting system of the heart, that's the inherent function of the heart, starting by the sinoatrial node and ending by the Purkinje fibers, and the other type of system which is modulating or the functions of the heart or contractility of the heart, which is like any organ in the body. Heart is being affected by the autonomic nervous system, as we have mentioned here, with its two big divisions, the parasympathetic and sympathetic nervous system. The activities of the conducting system uh, uh, of the heart can be influenced by the autonomic nervous system via the cardiac plexus below. And this is autonomic nervous system uh, being represented by the cardiac plexus below the aortic arch to the heart. According to the diagram in here, you can see the pathway of the sympathetic and parasympathetic being stimulated by the vagus nerve, and through this way it will come and supply the sinoatrial node and some other character and some other structures in the heart. The nerve supply to the heart, including the visceral sensory fibers to the pericardium, endocardium, and coming to the parasympathetic branches via the vagus nerve, which is here by the violet arrows in this diagram. The postganglionic parasympathetic fibers terminate on the sinoatrial node and in the AV node. The fibers of parasympathetic are reaching or going to the sinoatrial node and AV node and on the coronary blood vessels themselves, and this is important for their own functions. Vagus stimulation, as we know, it's a vagus, some sort, it's slowing the heartbeats. Vagus stimulation slows the rhythm and diminishes the rate of contraction of the impulses to the heart, leading to its no contractility it will be slowed. On the contrary, parasympathetic fibers, and those are coming from the cervical and upper thoracic by the greenish, arrows here in this diagram, from the cervical and upper thoracic, as we mentioned, chain ganglia. The postganglionic sympathetic fibers terminate again on the SE node and in the EV node. Those are the main pacemakers. The pacemaker is the sinoatrial node and its next station on the EV node still on the cardiac muscles and to the coronary muscles. And they are having very important function is through the physical activities and other pathogenic situations in the patients. If we are talk about, contractility of the heart is very essential and very important. The main function of the heart, as you know, is to contract. As we said before, the main function is to pump the blood, is to contract. And this contractility could be increased, and we call that by, as tachyarrhythmia. And if it is slowed, it will be called as a bradyarrhythmia. By the way, you have been seeing some of the tracings of the heart in different patients before. Yes, you didn't practice clinical situations yet, but it's good to know that the echocardiogram, which is this diagram which is shown in here, it is showing the activities of the heart. Like it is, and those activities or contractility is being expressed by some waves. If we are looking to start with from the left side as the P wave, P wave, P come P here and coming down a Q wave, coming to the R wave, coming to the S coming down, then going there to the T wave. Those P, Q, R, S are forming some sort of contractility or depolarization by activity is being manifested, depolarization and repolarizations of any chamber of the heart. So each wave is showing some activity of a chamber of the heart. Like this P is showing the activity atrial depolarization, and this is the contractility of the atrium. Coming QRS, this is the ventricular activity of the depolarization. To the T wave, it is, coming the repolarization of the ventricle. So each wave of those waves is showing the activity of chambers of the heart, and on looking and measuring the magnitude and the duration of each of those waves, we could judge on some diseases of the patients. Simply, the activities in relation to the contractility of the heart, as we mentioned earlier, that it could be tachyarrhythmia or a bradyarrhythmia. Tachy, it means rapid acceleration of the heart contractions. Bradyarrhythmia is contrary to that, slowing of the heart. Some examples for the tachyarrhythmias and some diseases of the heart, what is known as the atrial, say, of course, tachyarrhythmia could be atrial, could be ventricular. Bradyarrhythmia could be atrial, could be ventricular. About the tachyarrhythmia of the heart, there is a big group of tachyarrhythmia known as supraventricular tachycardia. Supraventricular means mostly atrial ones, and those are coming some known examples. You could see some of those patients, some patients with atrial fibrillations, or some people with atrial flutter. And those are very important to know that, because the patient with an atrial fibrillation could send an serious embolus to a brain vessels or to some other vessel to the intestine, and an embolus will cause obstruction of the blood supply in that area. Manifestations of tachyarrhythmia, if we are talking about the atrial ones, mostly the patient will have some sort of palpitations apparent. The patient will feel the heartbeats more and more and more. And if there is some sort of compromise, the patient will have sweating, will be drowsy, Mostly, such a patient must be uh, consulted in a hospital to see a cardiologist so as to continue the management. For the ventricular arrhythmias, very serious ones. And those, tachyarrhythmia and the ventricle, like the ventricular tachycardia or ventricular fibrillation, even. Ventricular fibrillation is a killing issue, and if the patient or the heart of any patient having this tachycardia or ventricular fibrillation, it might end with cardiac asystole at the end, and the patient could die by that. So it's important for the contractility of the heart to be perfect, I mean conducting system of the heart and the blood supply to each station of the conduction system is perfect. Added, the autonomic nervous system is perfect in supplying the parasympathetic and parasympathetic supply to the areas of the heart, either being affected neurological or some by other medications. Presentations of those patients, we mentioned that a patient with the ventricular tachycardia or supraventricular tachycardia, the presentations could be mostly some sort of a serious issue, and it could be secondary to some insult to the cardiac muscle, which it means insult to the conducting pathway of the heart, and the consultation to a cardiologist and management on emergency basis is very critical and important. Thank you very much for listening, and I hope you get what is needed from this lecture. Of course, as I am always stressing, go to your textbook again and you try to review each important issue. Thank you very much. Bye bye.